Good afternoon and good morning to all our distinguished colleagues and experts from across the globe. It is my absolute honor and privilege to welcome you all to this landmark academic initiative, this global webinar on renal replacement therapy in low resource settings, the challenges, the status, and the way forward, organized by the Nephrocritical Care Society. Before that, I would be describing little bit about the Nephrocritical Care Society. So first of all, again, I would welcome all of you to Nephrocritical Care Society. And as you have known it over last 2 years or so, we have made this as a revolution in critical care nephrology, and as a mission, we have taken this initiative dedicated to advancing the field of nephrocritical care through education, research, and collaboration. The whole idea is to improve the patient outcomes by promoting excellence in the care of the critically ill patients with kidney related conditions and fostering a supportive community of healthcare professionals. Now, the whole idea and the motive is to change, inspire, and empower. And as a result, we are here today, and I am humbled to see an extraordinary assembly of experts from India, Nepal, Sri Lanka, Kenya, Brazil, Egypt, Singapore, UK, and Australia. Nephrocritical Care Society currently is having more than 2000 members across the globe. Nephrology, critical care medicine, emergency medicine, anesthesia, pulmonology, internal medicine, and many more specialties are in the Nephrocritical Care Society. We have in last 2 years conducted the annual Nephrocritical Care Society conference, many review courses across the country, India, and also we are about to enter into the neighboring countries to conduct the review courses. We have conducted, I think, more than 22 webinars in last 2 years, quiz sections, monthly blogs from the experts across the globe. Now, we are also right now having global research. As we all know, Globe RRT survey is the flagship initiative which is currently ongoing. And many are in pipeline, and they would be definitely having their role in the
was giving a brief review of what we have done and what we are planning to do. So basically what we are aiming at with our survey that is floating around is to have some idea in specifically in low and middle income country how the practices of renal replacement therapy and management around it, how it is varied, differ, and whether we can come to some sort of understanding that what are the ideal practice in such resource limited settings. So that's the initiative part, and this is the first part of the few series of webinar that we are planning to go ahead one after the other. Now we have a distinguished panel here, and for the first session of that, and I have one of our good friend Dr. Ramanathan who will be helping out with me in running the first session.
I'm just about to introduce about the webinar. So this is just not another webinar, rather I would say a call to action. And we all know that across the continents, critically ill patients in low and middle income countries, they face the disproportionate hurdles in accessing timely and effective renal replacement therapy. Now, from infrastructure and affordability to training gaps and also the policy inertia, this is the global dialysis divide that we must address. Now, today's session, we will unpack what RRT truly looks like on the ground in low resource settings, when and how we should be choosing whether it is SLADE or CRRT or I would say, peritoneal dialysis also for optimal care. And most importantly, how we can build sustainable models through innovation, policy reform, and collaborative training. Now, this gathering is a testament to our shared commitment, like I would say the intensivists, the nephrologists, the policy thinkers, and also the educators to reimagine the RRT delivery in the ways I would say not only clinically that would look sound, but also locally relevant and globally just. So, without wasting further time, or I would say that let's dive in, not to just discuss the problems. Here, I don't think we should be only discussing the problems, rather, to create the solutions, because the world indeed is watching, because we have now almost 500 registered like attendees in this webinar. They are joining gradually. 28 countries people have registered. So I would say that world is not watching, rather the patients are waiting. So let's begin this academic journey, and I would definitely welcome you once again. And I would now hand over this session to Dr. Mohel Gudela, who is with me also here in Delhi, and he will be introducing the first panel to everyone.
Good evening, everyone. It's an honor to be here, and I would like to thank Dr. Tapas sir for giving me this opportunity. And we all know that Nephrocritical Care Society has reached globally and collaborated with many global leaders in this field. Now, it is also great to know that Nephrocritical Care Society has again, gone back to the roots where they want to actually, see what is happening in the low middle income resource countries and deal with the problems there. So, without wasting much time, I would love to share. Share the moderators and panelists for the first session. So we have so our first session for the discussion is resource optimized RRT in low resource settings, and I have the pleasure to invite Dr. Sananta Kumar Das sir. He's a consultant intensivist, Townsville University Hospital, Townsville and Queensland, Australia. Also, I have the pleasure to introduce the second moderator for this session, Dr. K. R. Ramanathan sir, Senior Consultant, Cardiothoracic ICU, NUHS, Singapore. Now, with this, I also take privilege to introduce our panelists. We have Dr. Namrata Rao ma'am. She is Additional Professor, Department of Nephrology, Dr. RML Institute of Medical Sciences, Lucknow, India. And our second panelist would be Dr. Subhash Acharya. He is Professor in Critical Care Medicine, Executive Director, TU Teaching Hospital, Nepal. Our third panelist would be Professor Dr. Shailendra Shrestha. He is Consultant Nephrologist and Renal Transplant Physician, BNB Hospital, Lalitpur and Nepal. Our fourth panelist would be Dr. Dilshan Priyankara, Intensivist, National Hospital of Sri Lanka. Also, sir is President of Ceylon College of Critical Care Specialists from Sri Lanka. And the last panelist for our discussion, first discussion, is Dr. Udana Ratnapala sir. He is a consultant nephrologist, also former secretary for Sri Lanka Society of Nephrology, Sri Lanka. Now, I would like to hand over this to Sananta Kumar Das sir and Ramanathan sir to take it further. Thank you.
Thanks, Mohan. Really, we have an august set of panelists, and I'm sure we should be able to cover some of the aspects of how RRT can be done in resource limited settings. Clearly, we have a mix of nephrologists and intensivists, and thanks, Tapas, for getting the mix right, because a solution may not just have one. Sorry, a problem may not have just one solution. It can have many, and clearly, we need to figure out by seeking multidisciplinary opinions when we are looking at practical solutions on the ground.
I was saying I'm really privileged to have such a mix of faculties around me and not delaying things. I would straight away jump into the first dilemma that I face when I was working in such a resource limited setting. Is as a whether you are an intensivist or whether you are a nephrologist, depending on what type of ICU you guys work. But there's always a dilemma between what are the resources which you work with and what are the monetary constraint that you have to go through to subject your decision for a patient who requires RRT. So I would ask the panelist as the first question is, when you are working in a resource limited environment, as a clinician, how do you prioritize patients for different RRT modalities in ICU? How do you think which patient will require a CRRT, which patient will require a SLED, which patient may do well with a intermittent hemodialysis, or how do you cater your decision based on patient, what type of patient it is, and what sort of renal replacement therapy you equate to them or join the dots between them. So what is the decision making pathway, or what is the decision making tree that you look for, that X patient needs to be started on CRRT and Y patient probably will get away without a CRRT doing a SLED? What's your thought process? I would request to see what the nephrologist initially think in this panel. Dr. Namrata Rao, if you can just highlight or show some light in that, what drives your decision in such a situation?
Um, Thank you, sir. I really thank everybody for having me here. As you said, most of the times, whether it's an intensivist or a nephrologist, we all find it very easy when we are talking about classical indications. There is nothing much to think about when you look at very classical indications like, say, volume overload, oligonuria, or azotemia, where you have a high bun. Again, blood urea nitrogen is something we take a little more lightly, possibly, than intensivists do. Especially so when there is an underlying chronic kidney disease or something. But generally, azotemia, say a bun of more than 75 or 100, as per different protocols, and a creatinine clearance of less than 15 or 10, as per again many other protocols. That would be something where there's nothing much in terms of thinking whether or not you would go for RRT. You would go for RRT. And then when you have the typical renal support indications, these days I'm sure nephrologists across the world are more supportive to you intensivists. We don't really bother you much when you tell us that we have a situation where we want to give more volume, we have a situation where we want to give more nutrition, where we need solute modulation, even though there is urine output. Even in those situations, I feel at least we as nephrologists, we have come halfway through, and we do accept that RRT should be initiated in such things. I mean, I know that during my PG time, we were a lot more, critical of our intensivist colleagues when it came to renal support indications. But over the years, as I've seen practice go on, things I feel we are midway through between intensive care and nephrology regarding classical indications. Coming on to situations where there are, where things are much bit more blurred, is where we feel the nephrologist at least feels that this is the kind of AKI which might resolve over the next few hours, or where there is some urine output, or when there is some diuretic response, and we feel that it's possible that if we were to not push the patient hard enough, the patient might recover from AKI. Especially the kind of patients that we got to see in these major trials too, like those which were early versus late trials. We saw that chunk of patients who actually ended up not requiring RRT. That is the sort of patients where we definitely would have a problem in where we would like to disagree and say possibly this is where a nephrologist generally tends to put his foot down. But I guess in most systems where we do work, it's always based on the equipoise, the principle of equipoise. It can't be the nephrologist or it can't be the intensivist who takes the situation into his hands, and we have to meet somewhere in between. I don't think I have answered your question in total, but I feel that maybe there are so many panelists that there will be a lot of opinions, including opposing ones too. So I'd like to hear them out too. Yeah.
Don't worry, Namrata. Clearly, we are here to provoke them as well. So, yeah, I mean, stemming from what Sananta started off, let me rephrase that same question in a different way. And I would be keen to know what Dr. Subhash from Nepal would think about this. Assuming that you have the protocols in your hospital, assuming that you have most of the things organized already. How would you approach, say, a shortage of resources in your setting? Let's say you run out of filter or you run out of some of the circuits. How do you modify decisions on dialysis when it really happens on the ground? Dr. Acharya, I'd like to pick your brain on it.
Yeah, I'm Dr. Dan Ratnapal from Sri Lanka. So let me give my experience from Sri Lanka over the last couple of years, after coming back from UK. So what we have is, first of all, the decision, in Sri Lanka depends on the availability of the renal replacement modality. Whether you have got a continuous renal replacement therapy machine, whether you have filter may be there, whether you have consumables. That's the most important thing. The second question is whether you have got a dialysis unit or a dialysis machine on board. Third thing is whether you do PD or not. So availability of the resources. For example, Sri Lanka for a 22 million population has got only 676 dialysis machines for AKI as well as for end stage. So that's all. Only 676 for all 22 million population. And the CRRT machines, because of this webinar, I looked into it. So there are 122 machines for the whole country. So, the availability is almost always at stake. It's quite difficult to find a CRRT machine or a dialysis machine when there's a AKI. So that's the first question. And the next thing that has happened is we have moved out of PD. For example, now for the last ordering of the consumables, we didn't order any acute PD solutions because acute PD has gone out of practice for last 5 years. I don't think we use acute PD as nephrologists in the country. So that's another thing that we could have used, and we are thinking of reusing in a low resource setting. So apart from the classic indications, the availability of the resources and the expertise. Now there are at least couple of ICUs which has got CRRT machines kept in place, but the expertise is not there. Either they don't have an intensivist or a nephrologist, or they don't have trained staff. So that's why in Sri Lanka, the intensivists like Dr. Dilshan and nephrologists like myself are working very closely to identify the correct modality of renal replacement therapy for the AKI in ICU, the first thing, and to keep minimal requirements needed to run an ICU in case of a AKI. And third thing, to train the staff. And even tomorrow we are doing a CRRT training session together for 100 odd nurses in the country. So that's how we approach our problem in Sri Lanka. Thank you.
So in our part of the world also, I think the cost is a major limiting factor. So we are also currently practicing intermittent hemo and sometimes SLED rather than doing CRRT. And as previously said, we are not doing acute PD in our ICUs. And so cost is a major issue because all the treatment that has to be taken care by the patient themselves. So it is so CRRT is even if we have trained manpower, it may not be used as frequently as it should be. So currently we are relying on intermittent hemo and sometimes SLED.
Yeah, thank you.
Thank you.
Para ver se ele precisa continuar em jejum ou se dá para liberar dele comer alguma coisa.
Sorry, somebody else is talking on the background. They may want to mute. Yeah. Thanks. I think these are practical problems on the ground. I'm just wondering with another question. With these shortage of resources, do you think there is a role for reusing CRRT circuits after sterilizing again? I'm just throwing whatever are the possible solutions, and I'd like to know whether is that something any one of the panelists have attempted. Yeah, Dr. Dilshan, what are your thoughts on that?
Well, I think there are pros and cons on this reusing of material. Of course, that reusable material definitely has its own advantages, like because it's reusable, your cost will be less, and your the sometimes raw material, the cost for the raw material, and of course the because of the new stuff coming up, that you might rely on the old stuff that you might be reusing. So and also because we are running into, like, heading towards a green ICU concepts, that reusing material would impact on the environment as well, and it will be available for you if you are reusing. On the other hand, the major disadvantage, I would tell you, will be the infection risk. I think there are a couple of studies, especially there was one study from Sri Lanka looking, I can't exactly remember the year. They looked at the reusable of dialyzers, and they have, come into a conclusion there's a significant reduction in the cost when you reuse them. So, but at the moment, we don't reuse any of the material that we use for either CRRT or hemodialysis because of the infection, mainly the infection concerns, and also the regulatory concerns. So the stuff that we use, that they definitely tell that it's not be reused. So in that case, that we are not allowed. One is on ethical grounds, and also from the patient safety point of view. So it's a question, but I think if the new developers are there, they might, rethink of developing stuff that we can reuse, especially the stuff which are very costly. So that's my opinion on reusing the stuff, especially because it's you deal with blood, so there's a high risk that complications can occur.
Yep, valid point.
Just one take, sir. Just one take.
Sure.
I think one thing that we are talking about is extending the filter lifetime. Like, at 72 hours, if you have a functioning membrane, people can, sort of extend its use to, say, another 12 hours or 24 hours or so. That's a different thing than reuse. Because typically, CRRT membranes do clog up a lot sooner than that, especially if you're running something like a filtrative modality. It's very likely that you will be clogging up by that time. You can try to, say, run a cycle with, say, heparin or something, but I don't think that sort of thing is really much. I mean, I don't see it happening all that time. I mean, in fact, I don't see filters lasting for that long at all. So that is one thing. I mean, typically in a low cost setting, if something like reuse is being talked about, we are talking about mostly dialytic modalities. I think Valentine sir is pointing out certain things on the
Chat. Yeah.
chat box. Yeah.
Yes,
Yeah,
so
I mean,
he is
those,
highlighting,
yeah,
sorry, he is
yeah, go ahead,
highlighting
sir.
that the sets are all pre-connected. It's very hard to reuse them, especially with the Prismaflex. If you're using, that's a code restricted use of the set. So one set can be used only once, and you cannot override those specification from the manufacturer itself. So that reusable or reusability of few machines is not possible at all, because that's how they business it. But Fresenius, yes, Dr. Lobo has said that they have replaced the hemofilter with a high flux dialyzer that can be used in the same patient, that can be used. But for a CRRT, I think reusability is a bit of a challenge because the filter clogs or clots, and the whole set is so sophisticated that cleaning the set effectively is a big challenge, and it may not be cost effective. That's what my presumption is. I don't know the specification of that, but definitely for intermittent hemodialysis, when I was working in India, probably it was a patient specific filter. The same filter gets used in the same patient as they come back again and again. So that can be a strategy that used to be used, but I don't know where we are nowadays. But at that time, the same filter gets washed and reused in the same patient. That was 10 years back. That's how it was. I believe that would have been the practice in few other centers where the patient comes with a maintenance hemodialysis.
I think the message is to use whatever the thing that you have, the machine or whatever, effectively. Then, I mean, your whatever the problems that comes, because when the filter clots, that do you use a new circuit or whatever, so then your cost goes up. So what message is to use them very effectively on the correct patient. So then your selection is good, And if your therapy is good, that makes a good, outcome.
Hmm.
The other thing I wanted to talk to ask what panelists think about is that there, for some time at least, we do have machines which offer a much lower dialysate flow rate. At least dialysis machines with, say, a dialysate flow rate of 100 or so. If you're looking at settings where a CRRT machine is not that readily available, maybe the panelists would possibly. I'd like to know how others feel about using SLED F or a SLED modality using a really low dialysate flow rate of, say, 100. It's like a go between CRRT and typical SLED, and it does cut down costs too.
Actually, I wanted to raise the same question. When we are talking about the CRRT, the first question is it really superior to SLED, even in hemodynamically unstable patients? As far as I know, the advantage of CRRT is only in patients with traumatic brain injury, who have a high intracranial pressure, or patients who are with liver failure. So in those conditions, may think of CRRT as a first line or superior to intermittent hemodialysis or SLED. But should we use CRRT in all such hemodynamically unstable patients? So the same question which Dr. Namrata raised. So I also want to add the same thing. What is the opinion of the panelist? Because I'm from Nepal, and as far as I know, we only have 2 centers in Kathmandu where we have the CRRT machine, and that is also very infrequently used. I am practicing nephrology for more than 10 years, and I had the exposure of CRRT when I was undergoing my ISN fellowship in Australia. And after that, for more than 10 years, I'm not using CRRT at all. I'm using SLED in all hemodynamic unstable patients, and the outcome is more or less satisfactory. So my first question is, why should I, convince my hospital administration to buy a CRRT machine?
I think it's a
That is the
valid
question.
question, Dr. Shrestha, because I think now we are actually questioning conventional treatment, and this is exactly what we wanted to do with this panel discussion. Clearly, the moment you start using SLED more frequently, you learn about it, you start selecting your patient more diligently. I'm sure you may be able to achieve a similar kind of outcome as you would with CRRT. Having said that, it's been drilled straight into our head that CRRT, the indications would be some of those which you mentioned, and in that hemodynamically unstable patient who is on 3 inotropes, it really takes a daring effort to do that, and probably in your situation, you're doing it because you're forced to do it, while others just don't want to try, and they're just driven by what would happen if this patient would crash. So I think that aspect is always a question mark, because you clearly don't know what would have happened if you had not used CRRT and had used SLED. Yeah, but again, I'd be keen to listen to other panelists if they have an opinion on this, or else we can move on to the next question.
Hello.
Yes.
I'm again from Nepal.
Ah.
Sorry, I joined a bit late. I was traveling. So anyway, I would like to add on with Dr. Shailendra's Sreshta. I'm an intensive base and working in periphery out of Kathmandu in a medical tertiary care medical college. So I have been using this RRT, basically this thing SLADE. And for CRT, as already discussed in Nepal, in my knowledge as per now, I think 2 or 3 centers they are providing it. Now the problem is choosing over SLADE over CRT is one thing. Apart from this financial aspect and everything, the lack of evidences, the evidence is still now what we have is like the evidence is still now SLADE and CRT more or less they are mortality wise or the outcome wise they are more or less similar. So for us, the intensivists who have a limited experience or practical experience regarding the use of CRT, it is very difficult for us to convince the stakeholders to start the service for CRT. And until unless we have a clear cut advantage of using CRT over other modalities of this thing RRT. So this is one thing challenges that we are facing for in favor of CRRT in my place. Yeah.
Yeah, that's clearly interesting to observe that, how we modify our existing systems to cope with some of these resource limitation. And I just move on to the next question so that we cover a bit more. I'd be curious to know how you train your ICU staff in RRT. So, because that was one thing which Tapas brought up in his intro, and I think that's very important when we talk about resource limited settings and how you get your resources organized or streamlined properly. So, and I'd start with Dr. Subhash again. Um, how do you usually train your staff in your ICU for CRRT or any renal replacement therapy that you use?
I think as a nephrologist, my training ICU staff is a little bit of a
Oh
stretch.
yeah, yeah.
Yeah, but one thing I do look for among my whenever I go to an ICU is that I do tell the nurses and the technicians looking after the CRRT there again that they should at least count the bags and the used bags. That is something that we have tried to drill into their protocols. It wasn't around there, and they more or less used to measure effluent volume just based on whatever was on the screen, not accounting for downtimes and all. So that is something that I felt was a positive change in terms of trying to tell them how to measure for used bags, etc., and that helped to a certain degree. But yeah, overall in our particular system, there are only a few specific ICU technicians who are trained in the RRT protocols already, and they are being used again and again. It is not as a part of protocol for all ICU technicians. But I'll pass on this question to an intensivist so that they can answer this better. Yeah.
Yeah, there are a few of them in the panel. Anyway, I'll start with Dr. Dilshan. How do you train your staff, Dilshan, in Sri Lanka for RRT?
Yeah, I think that's the most important thing, what I believe when it comes to, a complex treatment, especially in a critical ill patient who is on few inotropes or vasopressors and on a very high demands on the ventilator, and then you put them on a CRRT. And if you are the first person or the nurse that, had to deal with this CRRT, then you'll be nowhere. So it's always there's a learning curve for all of these, the staff. So what we do is that in our ICU that most of the nurses are uh, very well trained to run the CRRT and to troubleshoot them. And so how we began was like even when we first appeared in the ICU, that we had a dilemma how this works, how this machine works, what it really does. So it's all about how do you get that learning curve. So what we did that we as the intensivists that we had to learn how it works. So we should know how this works, and when it comes to troubleshoot, how to sort out these problems. So we went for sort of many webinars and workshops, and we got to learn, and then we launched from the college that CRRT Quest accreditation program. It's an island-wide one. That's so the nurse for both the nurses and the doctors, so they can participate and they can get accreditation on the CRRT after a couple of troubleshooting and learning from patients who've been on CRRT, and then get back to us and sort out their problems. And meanwhile, the technicians who helps us greatly when it comes to machine errors, when it comes to troubleshooting. So it's a mixture of getting the knowledge and disseminate it to the your staff as well as island wide, because it's not just your ICU that help patients. So it may be many ICUs. So we encourage a lot of especially the doctors and the nurses who are working in the ICU to collaborate with us and participate in these workshops. And we had good feedback on that, and we run that program twice a year. So and we get good response from them. And during the ward rounds that we teach, so if there's a patient on CRRT that we teach, if why this is it there, why the ultrafiltration is this much. So how do you tackle your fluid balance? So it's a learning curve for all of them. So when you get to know it, and it be just like, you know, handling your ventilator as well.
Yeah, great points. Sanant, any questions from your side?
Yeah, so just going a little bit off track, but as Dr. Dilshan was saying, there is an existing training method there. Just to see, like, people who are practicing in Nepal and in Sri Lanka, whether they are referring to a particular hospital-wide protocol for any sort of renal replacement therapy, or it is being managed by the experience of a technician or a nephrologist. Do you have a abiding protocol for each of the modalities, or it's just by experience of the technician and nephrologist? How do you approach that?
So I think it is the second thing that's predominant. So it depends upon the center preference and center experience in doing the renal replacement in ICU. And as previously said, we've got CRRT facilities uh, for cardiac surgery patients and liver transplant patients and other ICU patients in our hospital. But again, it is limited by the finances. So as far as other hospitals are concerned, if there is a crashing patient in the ICU, it is very less likely that he or she will be referred to our hospital for the purpose of putting the patient on continuous therapy. So that is my point. Thank you.
Yeah, let me answer on behalf of Sri Lanka. It's same again. It depends on the nephrologist or the intensivist expertise. For example, most of the hospitals there were CRRT machines both, but was not used until a trained intensivist or nephrologist, was appointed. So it's all depends on the center expertise and of course the nephrologist or intensivist training in CRRT. Otherwise, they would happily maintain their renal replacement with either intermittent hemodialysis or SLED. So CRRT, you need a lot of training. That's what, working through all these years, out of 122 machines I mentioned, only I think about 10 or 12 still not been used. So because people are reluctant, and so it's so-called killer machine also sometimes in some of the units, because when you use CRRT machine without knowing, without having any experience, there can be detrimental results and people are reluctant to use it. So we had to go against that mythology also, and needed a lot of training for nurses and doctors. Yeah.
All right. It's really interesting to hear your views, like how varied can be the practice, and especially the last comment that you made, that it can be life-threatening if we use the machine incorrectly or the way it should not be used, which is again an important thing. If you lack, not you in the sense, if we lack training and lack expert person to run that machine, or whether they are satisfying the indication of the modality or not. Now, Dr. Ramanathan, I think we had a good, fruitful discussion about this at the initiation of this whole webinar. Just I would like to summarize, and you can jump in to add if I have lost or if I've missed. Now we started with a decision making. How do you make a decision? And Dr. Namrata was nephrologist perspective. Some of the laboratory data like the urea and the blood urea nitrogen, creatinine clearance are important factor deciding the suitability of the dialysis. But I think that's in outside the ICU context. There are multiple things that as an intensivist we look, not only the numbers but also the patient, like how they are hemodynamically stable, unstable, whether they can take the dialysis or not, and then how gently we have to start and what modality. That is a universal rule, and I think all of us agree, irrespective of the resources, we have to prioritize the patient clinical condition and then think of the modality, which one we want to choose based on the patient's clinical condition and the numbers he has. The second phase, we talked about training, and it was really encouraging to hear from Dilshan, Dr. Dilshan, that they are doing an excellent job in the country to train the group, which is again a really commendable job to have more than 100 nurses getting trained in a particular modality and some uniformity of the practice. But when we talked about specific protocols that we or Western standards are, they go by protocols, they are probably lacking because of the varied practice that we have. Again, this is a point that we all know, and the gravity of not having specific protocol in managing a particular modality. We haven't explored that, what can be the impact of that. But as I can hear from multiple people, that it is very based on the experience of the nephrologist and the technician, how the modality and what modality runs in that hospital. We talked about cost cutting, and I think CRRT is difficult to manage. If you look for cost cutting, there's not many options that you can think of. Dr. Lobo was adding that we can change the filter, but again, which can be an option for a Fresenius, but with more advanced machine coming in CRRT, they are very code specific, and you cannot override the software to change or to reuse a circuit. So that's a big drawback, I will say, in resource limited setting. I think that's my summary points. Dr. Ramanathan, if you want to add anything into that.
I was saying that this was a fantastic discussion and a great group of panelists. I like the way some of the conventional wisdom was questioned in the context of how you modify things in a resource limited setting. And clearly, you know, we do it differently in our backyard. So can we learn from each other? I would think we can, and I clearly have more questions to ask them, but clearly, you know, we have run out of time. I'm sure Tapas will organize something similar again in the months to come, that we discuss this in greater depth. I thank all the panelists for being here. Really lovely having you here on the panel and discussing some of the important aspects of managing such a life-saving modality in a resource-limited setting. Thank you. Thank you for all your time.
That wonderful discussion indeed, sir. We would like to thank moderators and panelists for a wonderful discussion. So before we move to the next panel discussion, I would like to introduce this Globe RRT survey. Many of us know that, as a nephrocritical care research initiative, we have started this Globe RRT survey to know the practices around the globe, especially in the low middle income countries, and we can organize our thoughts and go ahead with the collaborations. Now I request the participants in the webinar to kindly go through this QR code. Please scan this, and then you can fill the survey, share your practices, and then we can go ahead. So far we have at least 32 countries. People from 32 countries have participated in this survey, and it's great. We would like to see more people coming forward and participate in the survey. With this, I would like to go ahead and initiate the next panel discussion, which is on CRRT versus SLED versus peritoneal dialysis, finding the middle ground in the critical care. Now, to moderate this session, this panel discussion, we have Dr. Pratima Ramchandran ma'am. She is Senior Consultant and Coordinator, Critical Care Services, Apollo Specialty Hospitals, Chennai, India. And we have Dr. Valentin Lobo, sir. Sir is a faculty nephrology, KM Hospital, Pune, India. And we have our wonderful set of panelists. First one being Professor Dr. Lalit Rajbanshi, Head of Department Critical Care Medicine, Birat Medical College and Teaching Hospital, Birat Nagar, Nepal. We have Dr. Flavio. Sir is a critical care medicine specialist working in University of Rio de Janeiro, Brazil. We have Dr. Pedro Tulio Roca, Head of Nephrocritical Care Committee of Brazilian Society of Intensive Care from Rio de Janeiro, Brazil. We have Dr. Saurabh Sharma, sir. Sir is Assistant Professor Nephrology from Vardhaman Mahavir Medical College, New Delhi, India, and also involved in dialysis working group, ISN,
also an assistant editor, ISOT newsletter. We have Dr. Ahmed. Sir is an assistant consultant critical care, King Abdullah Medical City, Makkah and Saudi Arabia. So now we would like to go ahead and initiate the discussion. Over to you, Pratima ma'am and Valentin Lobo sir.
Nice meeting you. This platform, I think we have overlapping discussions. So already, I think we have already come into the middle grounds of CRRT, SLED, and peritoneal dialysis is yet something which we are going to introduce in this discussion again. We are going to add up to the heat and replacement. So, Dr. Valentin Lobo, sir, please, can you start?
Should I start with a question? Yeah. Okay. So already, I think Dr. Namrata already threw sort of the ball into people's court by saying, "What about SLED F?" So I would like to know from the panelists a sort of a 2-point question over here. Somebody asked, "Are there conditions where SLED is definitely inferior to CRRT?" And I think the discussion that happened earlier said it takes a lot of courage if you have somebody who is on 3 pressors that we think we should go for CRRT. But sometimes when finances or other things dictate that we can't, as I had to 5 days ago, the patient said, "I cannot afford CRRT. Ejection fraction 20%, myocardial infarction on Saturday night, thrombolized on Sunday on noradrenaline 30 micrograms per minute, vasopressin 2.4 units per hour in pulmonary edema, and I have to give him RRT." And he could not afford CRRT. We went on with SLED. So is there any, I would like to know from the panelists, is there any real difference between SLED F? We have machines which can run 24 hours at a time. They can provide both dialysate and replacement fluid online. That's what we call SLED F. The dialysate flow rates can go as low as 100 ml per minute, and you can give unlimited quantities of substitution fluid, as it's called. So is there any real difference from CRRT? And if there isn't, then what is the barrier to our using this more widespread in India? Because I think, or in any developing countries for that matter, why do we need to run behind the CRRT machines, commercial filters, commercial bagged fluid? If we can do this, what's the difference and what are the barriers? Over to anyone who would take.
I think I can start. First, I would like to thank the panelists for the kind invitation. I'm Pedro Tulio. I'm from Rio de Janeiro, Brazil. I think this is a great opportunity for us to have this talk. We always on symposiums and congress. Most of the colleagues that are sharing their experience are from Europe, from the US, and we know that we don't have the reality. So this is a very important occasion for us to talk about our reality, real world situations. And we, for many years, doctor, here in Brazil, we did not have CRT machines. Or if we had them in very few centers. This is something that changed with the pandemic. With COVID, I think most of the manufacturers saw that they wouldn't have enough machinery to take care of all the patients, and they brought more CRT machines, and the cost is still higher, but it's lower than it used to be. So this is what we say in Brazil, it's a good inheritance of the pandemic. We started to have more centers with CRT. I agree with you, and Dr. Flavio, my colleague from Brazil, can also speak about SLED, that we have a large experience here in Brazil. Up until 4 or 5 years ago, I would say there were almost no CRT machines, so we basically only had SLED. But even SLED at 100 ml per minute, as you said, doctor, that would total for our over 6 liters of dialysate dose per hour. That's a high dose. And we see some acid-base disturbances and electrolyte disturbance, mainly phosphorus. You have to be very careful with phosphorus. And in critical, very critical patients, even 100 ml per minute, I think this interferes with their hemodynamics for all the osmotic shifts that are lower when we have CRRT. And the neurocritical patient, the patient with brain injury, being from trauma or being from a stroke, it's a population that it's proven to have worse outcomes when you use other therapies other than CRRT. Having said that, SLED's a good option. I think Dr. Fado will share his experience as an intensivist with SLED for selected patients. But CRRT, we need to decrease the cost, and I like very much the previous panel that talked about this. I would just like to share one tactic that we use here. It's very important to say that the kits, the manufacturers, they advise to change it every 72 hours. They do not demand. You can go over 72 hours. The machine will alert, oh, you have passed 72 hours. It's important to say that this, if the dialysis of the patient metabolically is still stable, you can go, and we have gone up to more than 100 hours of use, and this is a good way to save the circuit. And that's using citrate anticoagulation. No other way. Citrate anticoagulation, you need to have a protocol. It's a higher cost initially, but it's cost effective on the long run because you can use more time of your kit, of your filters, and this is something we always discuss.
My experience in my place, CRT, as I already told, CRT is a kind of like not possible, not feasible in our setup, at least in my center. So we definitely right now rely on the SLADE for those patients who hemodynamic unstable patient in basically in the ICU setup. So prolonging the problem what I face, continuing with the we have to rely on the conventional ISD machine for the SLADE. We are using the same machine. Now prolonging this thing, coming down the flow up to 100, minimum to the 100 ml. The problem is, and extending the duration beyond 8 to 10 hours. The problem is I am facing is, again, the problem with the filter, the life of the filter. It gets you have to use a lot of anticoagulations. That is one, the part is there. The other part is basically this is the monitoring part. That is again the challenges, as we already discussed regarding the training of the staffs. We still have to rely on the nursing staff for running RRT in our ICU setup. And to my experience, the outcome delivered by these the limitedly trained staffs is really a challenge to monitor a patient for 10 to 12 hours. For a patient who is on multiple of inotrophs, and that too you are challenging the by increasing the duration as well as the coming down the flow. So this is a kind of big barrier for me to use or the conventional, the ISD machine as like a CRT or prolonging the duration. So this is what I am facing in my place.
Coming away a little bit from the CRRT and SLED, how many of us use PD, peritoneal dialysis? Is there any protocols we use? I know intensivists don't go directly for it, but more of nephrologist. I think they are a little bit comfortable on that.
Yeah, hello again.
Anybody wants to comment on it?
When I was when I was a resident, we used to have that intermittent PD also for such hemodynamically unstable patients in the ICU. But at that time also, I didn't find that the outcome was very good. So personally, though we all promote CAPD, personally, I'm not in favor of intermittent PD in ICU setup. SLADE is, in my view, is much better than intermittent PD. But I think there are a lot of pediatric SLADE is much better than intermittent PD in my view. But I think there are a lot of
Is it
pediatric
because of the sorry, just to interrupt, is it because of the procedure and its complication, or is it ineffective? I just want to interrupt to make things more
yes,
clear.
yeah, partially it's I found that it's ineffective, and partially because the intermittent PD catheter frequently gets blocked, and so the flow issue then comes. So I personally feel that SLADE is better than intermittent PD. But a lot of pediatric nephrologists, they still use intermittent PD in infants, where it's difficult for us to do the hemodialysis or the SLADE. So maybe in such category of patients, still intermittent PD may be useful.
Dr. Flavio, you want to give me your inputs? Anybody else in PD? Yeah, please.
Okay. Good morning, good afternoon, good evening. My name is Flávio Naku. I'm speaking from Rio de Janeiro, Brazil. And I have to tell you that it's an enormous pleasure and privilege to take part of this big event, very well organized by my good friend Tapas and colleagues. I applaud the idea of getting colleagues from different countries to share experiences. In my country, in Brazil, we have very good hospitals and very bad hospitals. The money is not well distributed. It's very heterogeneous. So only a few hospitals in a few cities will have the continuous renal replacement therapy. This is not the reality for the most hospitals in Brazil. In my hospital, we do have. So, but most of hospitals don't have. So I have the experience, and we use in very unstable patients renal replacement therapy. But this is not the experience of most colleagues in my country.
I understand, sir. Sir, is there any ways in which this cost is cut in CRRT? Can we adjust the logistics or do any cost cutting in CRRT? Like particularly, sometimes we use different bags, the replacement solutions. So there are certain things which we like individualize or just tailor it to the institution. Maybe it is not evidence-based, but we do a little bit of tweaking to cut cost because of the resources. Do we have any particular thing which is practiced just by practice experience? Anybody else or anybody can from the panelists can give their inputs.
So I think, in the next panel discussion, Dr. Vivek Gupta is there. He's one of the people who has made very significant innovations in reducing the cost. Something that I do, if you look at, we talked about the filters and how we can't reuse the filters, but the filter is a one-time cost. It's the fluid which is so very expensive. Now, if you look at the acute PD dialysate fluid, it costs about 75 rupees a liter, and it comes packaged as 1 liter bottles. If you use the Prisma Sol 5 liter bags as dialysate fluid on a CRRT machine, it is 500 rupees a liter in Indian rupees. That's the difference. So I sometimes, on the dialysate scale, I hang an acute PD bottle. It only means that you need more nursing staff because the change of that bag is going to come every 1 hour or every 40 minutes, depending on the flow rates. So we can do that. Many years ago, in 2004, we published a paper in Indian Journal of Critical Care Medicine on the first 22 patients in whom we had done CRRT. It was done on a machine which I had made myself by removing pumps from other dialysis machines. We used acute PD fluid as dialysate, and we ran it with those ICU infusion pumps. We used as replacement fluid, again run with infusion pumps, we used 1 liter bottles of ringalactate or 5% dextrose, adding calcium, adding magnesium, adding bicarbonate to make it up. And the total cost per day was 5,200 rupees a day, including monitoring of APTT every 8 hours for anticoagulation. Today, the cost of CRRT at 25 to 30 ml per kg per hour for an average Indian is something like 25 to 30,000 rupees a day when we use the conventional fluid. So that is really the difference, and that can be done because in India, I think we have plenty of manpower.
Dr. Flavio, yes.
Yeah, sure.
Yeah, I have read that some of the centers in Brazil, they use large volume PD in acute cases also. Large volume PD using the tank of catheters. and the outcome is good in those cases. So can you tell us something about the technical aspects of the large volume PD using the tank of catheters? Because that is not done, as far as I know, in South Asia.
Pedro, could you help me with that? Did you understand the
Okay.
question?
Yes, yes. I think Doctor is talking about the experience of the Botucatu group led by Dr. Daniela Ponce. She has many publications on the subject, and she has a recent one, 1 or 2 months ago, and she has a good experience of PD. She uses high volume PD for cyclers, and she has most of her works, they show equal mortality rates to when compared to SLED or even CRRT. And when I mean high volume changes, she used upwards of 15 liters per day of changes, and she has a program that the nephrologist places the tank of catheter, and we are very proud to have this center here in Brazil that's one of the leaders in PD for acute kidney injury. Dr. Daniela Ponce from Botucatu. Botucatu is a small city in the inner state of São Paulo, but she has a very large experience, and she's one of the leaders in publications on this subject worldwide.
Dr. Saurabh has his hand up, and as a nephrologist, Dr. Saurabh, would you like to share about PD?
Yes, sir. Good evening, everyone from India, and good morning, good afternoon from other part of the world. So, first of all, I would like to congratulate Dr. Tapas for such a wonderful initiative and such an academic extravaganza. So, sir, like for regarding hemodynamically unstable patients, like in our setup, being working in a public setup, we have all three modalities because I'm working in Safdarjung Hospital. It's one of the largest tertiary care hospitals in North India, and we have all three modalities: CRRT, SLED, and uh, we can do CAPD also. But we need to individualize the therapy as per the patient profile. So if patient is hemodynamically unstable and in a neurosurgery ICU with acute brain injury, cerebral edema, we prefer CRRT. And in other patients, we always prefer SLED. And in patients with coagulopathy, we prefer SLED. But we do CAPD also in some patients where, like PD, we put soft catheters and we do CAPD. And later on, we can continue CAPD in these patients after discharge if the patient is CKD. And putting a soft catheter and tunneling later. We don't tunnel it. We just put a catheter and start PD from the day zero itself. And later on, while discharging, we tunnel it and continue CAPD. Patient can continue CAPD at home also.
There's a comment from Dr. Narayan Prasad that it's not true that PD is not done in South Asia. We do PD with the cycler, he says, and many times manually also. So the cycler works really well in such situations, especially in patients coming out of cardiac surgery. The cardiac surgeon implants a soft catheter with the pre-sternal approach, and we just put them onto the cycler in the post-op period. It's very much more economical than CRRT, and it works just as well in that situation. I think that's what Dr. Narayan Prasad is saying.
Yeah, many times in ICU settings, when cardiovascular surgeons thinks that the patient is likely to develop AKI, they come with this PD catheter in situ, and what you have to do, you have to go and connect with the cyclers, the proper advice how much you want to do. So that is very common practice. Particularly when you are talking about the resource limited settings like ours, where you don't have too much of the CRRT machines, you have multiple patients to be connected online. That is the one easy options, and the cycler machines do well during that period. They gives you the stability, gives you ultrafiltration. You can have a good solid removal, but this all depends on how much experience you are doing. Many times we have done with this stiff catheter also connecting with the cyclers. So it is not that what is your skill, what is the requirement at that point of the time when you are taking the decision to go for any modality of RRT. What is there in your hand? That I see.
So how much PD fluid you use when you use cycler? in acute PD? How much
Yeah.
volume of PD fluid do you use?
Usually we start with the 1 liter with 30 minutes of the dwell times, and gradually you can increase the volumes depending on the tolerance and requirement. But that gives a very good clearance. Half an hour, 30 minutes of this dwell times, and 1 liter of the exchange you can start with, you can increase gradually. So that is a good enough.
Dr. Vivek Gupta, can you give your inputs? Cost cuttings
Yes,
on CRRT?
good evening, everyone. First of all, thankful for allowing me to participate in this wonderful discussion. I was listening silently. Uh, Before coming on this, just few comments. Uh, why we are discussing that which is superior or which is inferior? We all know it's a dialectic modality. And why we are thinking that I will do CRRT, I'll do SLED. When my patient is hemodynamically unstable, as Dr. Lobo said rightly, that acute MI patient having on triple inotropes with a vasoinotropic score of 80 or 70, which is very common in Indian scenario or in resource limited situations, because these present very late to us. I will be going for CRRT because I would not like that even single episodes of hypotension should happen to my patient. Once this patient, the same patient is stable after 72 hours or 96 hours, possibly if needing further, I will go for the SLED because now this patient is stable and least chances of having a hemodynamic instability. That is one. Second, regarding the fluid, as Dr. Valentin Lobo was saying, routinely we are using a different fluids, not the Prismasol. Prismasol is I'm only using in those patients where I'm having acute hepatic dysfunctions or acute hepatic injury. Otherwise, I'm regularly using a PD fluid and the normal saline with addition of the other electrolytes like a calcium gluconate, soda bicarbonate, or magnesium. And this is working so well. Why I need to add so much cost to the therapy? This is one aspect. Second aspect, filter life it was being discussed, and cost of the therapy was being discussed. We when we are doing CRRT, our aim should be we can extend it as long as possible. If I can extend it to 96 hours, 120 hours, what is the problem? If my filter is working well, I'm not following the company rule that 72 hour is good enough to take out the CRRT. Lot of most so many times our filter goes up to 100 hours or beyond that. If it is working well, this is perfectly all right. We have to make adjustments because what happens, changing therapy depending upon the tailoring the therapy according to the need of the patient. For example, I started with the CVVSDF. I'll restrict my filtration fraction. I will see that I'm achieving with the our target flows and target um, effluent, that is around 30 ml per kg per hour effluent dose. And I will tailor this therapy because I know that when the CVVHDF mode is there or CVVH mode is there, it is going to cause more stress on the filter and filter life is going to decrease. So once these metabolic factors settles down, only a dialytic part is there. Definitely, I'm going to come down to the CVVHD rather than going for the CVVHDF. I always focus on exceeding filter life. And in my cardiac unit, so many times we are in a situation when patient is having upper GI hemorrhage, we are not able to give even these anticoagulants because I do not use citrate deliberately for all my patients. The reason is I am doubling the cost actually. And how many hours we can extend? It may be just 10 or 12 hours. So there is no point of using citrate. As far as I'm concerned, I'm not saying that others should not use, but restricting the cost of the patient of the therapy is going to allow me to serve much more higher number of patients whom I can do who are from the middle income group or low income group whom I can offer the CRRT. And this is how I'm running my CRRT program in our hospital. We have 4 CRT machines and rarely my any of my machine is free. We have a 200 bedded cardiac unit and its 4 machine is only for the cardiac unit. It is running and at a very cheaper price with a successful my average run if I calculate it very shortly we'll be publishing it also. It's without heparin more than 40 hours. So I keep playing with these all parameters and we can increase the filter life that help us to do CRRT with the limited resources and with a lower cost.
That's really very good inputs. I think 40 years is quite a significant time, and it is really a boom for a lot of us. It's really good. And anybody else who have changed some protocols or tweaked the methods to increase circuit life? Anybody, sir? So, yes, they're asking Dr. Vivek sir to elaborate. I think he has elaborated already, but is there anything else?
Not much. The only thing, keeping a flow, the most important thing I always look for, and I'm very aggressive. If my access line has some obstruction, I make sure that I'm putting a new access line, because that is the biggest cause of reducing the filter life. And in Fresenius, I had used Fresenius as well. So in Fresenius, we had an opportunity to flush these lines. So if my line is not running with the heparin, I'm going to flush my line at a regular interval. And my technicians, my nurses are trained. It takes some time to train them, but for last 17 years, I'm running CRT program, and we do not have this. Very rarely it happens. Means my team has to answer me if the filter live, if the patient is CRT stopped less than 24 hours. Why it has happened? What went wrong? We look for the feedback mechanisms from our machines to see that what was the issue, whether downtime was higher or whatever, and then we review it, and we on those feedbacks we go for the retraining of my staff. This is how we go.
Yeah, I don't think we have any more specific questions except one that maybe, last month at Criticare, Dr. Tapas and I, in an informal discussion, what we were saying is the only thing that perhaps the only disadvantage of doing what Dr. Vivek Gupta's team is doing in an excellent way is that we don't get bagged fluid of more than 1 liter for any of these others. And now it's very interesting. All Indian companies make intravenous fluids up to 1 liter, but not more than that. But the same companies will make irrigation fluid with the same composition, but marked not for intravenous use for TURP patients of 3 liters. So we need to perhaps, and I would throw this to all the panelists, put up an advocacy to the companies which are making fluids. If you can make TURP fluid in 3 liter bags, why can't you make intravenous fluid in 3 liter bags specifically to bring down the cost of CRRT? Because that's what we've all been talking about, that if we can bring down the cost, then the CRRT is it. Again, Professor Narayan Prasad has said, we used to make fluid for CRRT as early as 2002 when we started at SGPGI. And that's what we at KEM in the 1980s, we used to do it because we had our own saline department. So all sorts of fluid would be made in the saline department, PD fluid, intravenous fluids. And in those days, the cost was less than 10 rupees a liter. That was our cost. And then, of course, with the regulations that came in about animal house and animal batch testing, we had to shut down the saline department. So I would like to hear from any of the other panelists what they would think of, one, making our own fluids, and two, advocacy to companies if they can make TURP fluid of 3 liters and intravenous fluid of 1 liter, why not just go up and give us 3 liter bags?
Sir, I think
Yes, sir, please.
the real issue is regarding the cost of the bag itself, and the bag it needs to be imported, and that's why the companies are not able to do that. I
But
think
they
so.
are using the same bags for TURP fluid.
Yeah.
And that is very cheap.
Yes, sir.
I think it is very good, valid point. If we all just advocate, and I think this would come in very near future. We did talk about the SLED diff, and difference between the CRRT and how we opt this. And the CRRT availability is quite a question. Most of the hospitals, as previous said, there are good hospitals, there are bad hospitals. Depends on the resources. That's what he meant. I believe. So we did also talk about the PD, the peritoneal dialysis. Where is the common ground? Yes, some people some doctors are comfortable using it. Dr. Shaurabh Sharma did give his inputs about having a soft catheter and not tunneling it for quite some time and then getting on with it. So cost cutting was the like the most attractive topic today, and we did discuss about how the filter life can be prolonged, how the fluids make a difference. Yes, we all talk about resources and how to do it in a very uh, protocolized way. If we have different protocols for the institutions, or at least we can make some guidelines for the resource limited setups, I think more patients will be benefited. So this webinar will take it forward, and I think it is a very important point which we have to keep on discussing even after this webinar is done. Yes, and there was also the detailing of how different modes of CRRT, CVV, DHF, and how it is better to reduce the stress on the filter. So all these things were discussed, and anything else along with the CRT, SLED, and peritoneal dialysis, if the panelists we can move to the next session.
So, Dr. Pratima, as you have told, like we are about to write the take-home messages, and we will be also discussing with the policyholders and also the companies also. Like as you have told, that we need to do something. We cannot like only talk about the problems. So that's the whole idea and aim of conducting this type of webinars. So maybe we'll be putting it as a newsletter, and we'll be also sending it to appropriate authorities. Yeah.
It has opened a lot of, I can't say windows, it is more of doors. Yeah. And our discussions were very filtered. Yeah. Yeah. So we will start with the replacement soon.
Thank you. Thank you.
Yeah. Thank you. Thank you, everybody. Thank you, all the panelists.
Thank you.
So thank you so much, Pratima ma'am and Valentin Lobo sir and all the panelists. It was indeed a fruitful discussion, and a lot of innovative ideas have been pitched in. So I mean, like we would love to take this forward in the form of newsletters, as Tapas sir has told. And now we would like to go ahead with the third and final panel discussion. So the panel discussion is about training infrastructure policy framework for RRT in low middle income countries. And for this, we would like to, it is my privilege to introduce Dr. Prashant Nasa sir as moderator for this panel discussion. Sir is working in Department of Anesthesia and Critical Care Medicine, the Royal Wolverhampton NHS Trust Hospital in the United Kingdom. And also our second moderator for this would be Dr. Yes Javeri sir. Sir is Director for Critical Care Medicine and Emergency Medicine, Regency Super Specialty Hospital, Lucknow, India. And our panelist for this discussion would be Dr. Narayan Prasad sir. Sir is Head of Department Nephrology, SGPGI Institute, and Lucknow, India. Dr. Bruno sir is nephrologist from Brazil. Dr. Vivek Gupta sir, consultant cardiac anesthesia and intensive care, Hero DMC Heart Institute, Ludhiana, India. Dr. Fadil, consultant general critical care medicine, Egypt, and also sir works in other hospitals like King Abdullah Aziz University Hospital, Jeddah. We have Dr. Yesher. Sir works as a critical care specialist and critical care nephrologist in Rui Family Hospital Veterans Mission, Nairobi West Hospital, Kenya. And I would like to hand over the discussion part to Dr. Prashant Nasa sir and Yash Javeri sir.
Good evening, everyone.
Yeah.
At the onset, thanks Dr. Tapas for organizing such a wonderful academic feast. And both of us are here to moderate this session, Dr. Prashant Nasa and me. And we'll start with the first section on training about RRT in resource limited settings. The first question comes, how do we engage more of manpower who are dealing with renal replacement therapy to treat such patients? The manpower requirement would be a clinician, it could be nephrologist, intensivist. The first question probably will be to Dr. Vivek. If intensivist or nephrologist is not available, who can be trained and how he can be trained to take a call about renal replacement therapy? Thank you.
Okay, very good question. That if nobody is available, if intensivist is not there and nephrologist is not there, any physician who is knowing everything about the patient, whosoever is looking after it, can be a primary team physician, it can be any other physician if intensivist is not there, may be a lead for this. But as we all know that now it is a person who is knowing everything, because we cannot take kidney as a separate organ, that okay, there is a problem with the kidney and it should be treated. The patient has to be treated as a whole, that for what we are dealing, we are needing RRT, whether it's a uremic issues or it's a volume overload, which is very common in the intensive care unit, or either it's a metabolic correction which is required. So anybody, any clinician who is well aware about the patient and well aware about the modalities. But one thing is important, that he should be trained for it, for choosing a right thing. However, because nowadays it is the everything is available online, and teleconsultations are quite common. So a clinician may approach to the nephrologist or intensivist who can guide them for choosing a right therapy or right prescription, because the prescription is something very important after thorough evaluation of these patients. So it can be approached if they are not readily available bedside. They can be complicated.
Very right, sir. So we should train our manpower, clinicians, nurses, ICU technicians, and the dialysis technicians, especially in identification of acute condition. Obviously, if it is not an acute condition and renal replacement therapy is not an urgency, then nephrologist should take call. Otherwise, it should be a multidisciplinary approach, especially in acute life-threatening situation. Dr. Prashant Nasa, your questions.
Thanks, Dr. Yash and Dr. Tapas, Dr. Sananta, for building up this network. I think there are so many fruitful discussions I am hearing for last nearly half an hour and more. Just continuing on what we heard from Dr. Vivek, and then of course I will pitch in other panelists. Dr. Vivek, just continuing with you. You mentioned that since there are always challenges related to the workforce, we are short of hands, whether it's nurses, it's the physicians, and sometimes there are very few resources available, especially in a pandemic like situation. I'm working so-called in a resource-rich setting, but pandemic-like situation, and then of course, which part of the world we are working on, you are always short of hands, especially in intensive care unit, depending upon which time you are working. So then how you ensure competency of these staff, that's always a challenge which I believe comes as a part of the training. You train them up, but how you manage their competency, when how they are performing, how you look up as in your particular unit, because that's what I understood from you is a very oil unit, and you have built up so much resource limited setting, looking at that aspect and build up so cost effective solutions in your intensive care unit. So how you manage competencies of these people?
See, it basically first thing is to train them that how to run this safely and effectively. That's one. Second is the infection control practices. We monitor it that there is no infection control. Means there is no infection in these patients through the lines or whatever circuit, extracorporeal circuit we have. And the third thing, how what is the duration of my therapy? Whether I achieve the target, how much target we have achieved. Suppose if I had targeted that my ultrafiltration should be this much, so are we achieving approximate 70-80% of that, or we are lagging behind? So these are the common things we see. We evaluate. First, we train them. We, after training about the basic things, basic pressures in the circuit, basic pressures of the filters, when to alarm, when to ask about it, that these are the problems are happening. So what system we have at currently? We have a trained technician and trained nurses, because these nurses are ICU nurses, so are loaded with lot of work looking after ventilator, our ECMO programs, are feeding the patient, giving, administering drug, every all ICU work they are doing. So these technicians are supporting them, because they are also well trained for the CRRT. They are dialysis technician or even ICU technician. They have been trained for the CRRTs, and they are also taking care simultaneously. Then we look for the downtime very categorically for individual patient, and we analyze it. Which patient, why it happened. If it is beyond our expectations, then we look for ask for the cause. for root cause analysis, and then we go for corrective action. That it was some genuine reason, or it was just a casual approach. And then we counsel the staff, we train the staff again, and this is how we work for this improvement of the system.
Thanks, Dr. Gupta. Coming to Dr. Zawadzki, if I am pronouncing your second name correctly. So how do you do it in your setting, looking at the competency aspect of your workforce, what minimum competencies you look at them, and then are you also looking into more of a reactive approach of looking at their competencies, or maybe do a proactive approach also looking at their competency?
Okay, so first, thank you very much for the invitation, and it's a pleasure to me to be with all of us here discussing these important topics in our practice. So nowadays in my practice, we use an approach that is more a proactive approach. So we try to train these physicians and these nephrologists that are inserted in the care of these critical care patients, and we actually schedule regular trainings during certain period to try to get that all these physicians are compliance with their trainings and protocols that we use here in the setting. But this is sometimes difficult to guarantee because we have the turnover of the team, and sometimes it's not simple as I'm saying. And of course, we need to have the data and to monitor the outcomes to understand that if things are doing well or if we need to change something, taking care of this training of these physicians. So this is, I think, this is the point.
Yeah, thanks. Coming to Dr. Ibrahim from Egypt. So what do you do for training and competency in your systems? And then maybe you can talk about your national policies also over there.
Yes, thank you for this opportunity. I'm enjoying since 1 hour to hear from different countries, different ideas, different plans. So in Egypt, I started my journey in the critical care actually in 2008 in Sheikh Zayed Specialized Hospital, and it's a very specialized hospital and a good hospital in Egypt. And we have the CRRT machine since then. Then after now 2024, I just got an idea that I have to start to develop, and I am the author of the first nephrocritical care book in Egypt. The first thing is the learning, the training. This is the most important. As you mentioned that we need to, away from the nephrologist and the intensivist, we need to unify the program and the training. That's why an idea came to me that need the collaboration of you of all, and I am glad to that Nephrocritical Care Society can take. In intensive care, we have every 2 years we are doing the advanced life support. We cannot do the intensive care without advanced life every 2 years. Why? We should start to plan or to dream to have renal replacement therapy life support for 4 years to unify these marvelous plans, marvelous ideas. Dr. Vivek, first time I hear from him and I see him and admire his way, this will, I think, will decrease costs, will encourage more people, more nurses, more intensivists. So this is my ideas, and I hope it good will sounds for you.
Thanks, Dr. Ibrahim. I think that turns into a very, very important part why we are doing this webinar. Is also one of the context is to build up collaboration, to build up research networks. And I think the first initiative was looking at the snapshot, what we are doing into, these low and low middle income countries, how the practices are varying. And, as every one of you are mentioning in last 1.5 hours, there are different practices we are hearing. I think the survey actually talks about that. We need to capture all these differences, and I think that will build up how the future research will be taking,
how the future research will be guided and informed from this survey. So I request you to be part of that, and many of you are already part of that core group, and of course helping us out to reach out to the different people. Building on that, I will also invite Dr. Yash in a minute. We come to Dr. Prasad. So you have been working in a public hospital for some time, and I was reading your message in the chat box that you build up some cost-effective solutions, looking at some innovative ideas. So what do you think where we should do a build up a research, and what are the things in resource limited settings a research should be looking up in next few years? So what will be your ideas where we should move from?
Yeah, thank you very much for these invitations and making me part of this great webinar. And really, when you look at the front of the research, then when I will say one very simple things, it took about 4 or 5 decades to define acute kidney injury. So now after the 3-4 decades, when in 2002 when I was the resident, there was one survey came of AKI definition. There were 35 definitions of the AKI in the literature. And then now subsequently we become so it is all research, and that bringing into the practice is usually the gradual evolving phenomenon. So it's not a one-day jobs, and gradually we understand that initially when our patient who used to be so sick, we need to push every patient for CRRT. Gradually we have learned that no, not all patients are required to start on the CRRT. You can opt for the SLATE modality, and that has equal outcomes. One randomized controlled trial done in our ICUs here with the critical care medicine department of SGPJMS that have well established the CRRT and SLATE has no difference at all. Gradually over the times we have seen the machines quality are evolving. The way we are getting the ultrafiltrations from the machines are totally changed the last 2-3 decades. So these are all evolving things, and gradually I think the most important things there is the cost effectiveness for the country like ours, particularly in the low resource settings. And that should be the one area when like Dr. Vivek Gupta has stated that. So do you think the CRRT once they started, it should continue for the 96 hours? If your presence becomes stable in next 12 hours, 8 hours, why to continue this costly therapy for so long periods? Stop this, shift your patient to the SLATE, shift your patients to the intermittent dialysis. Aim should be there to try to shift, even not for the SLATE. The most effective way of removing the solutes, correcting electrolytes, taking care of all acid-base balance is the intermittent hemodialysis. If SLATE is again, patient becomes more stable. Forget about this. Shift the patient on intermittent hemodialysis. But there should be, this should be the study by protocol wise. And since many of our ICU do not have the very uniform stable protocol across, no, and every unit has the different kind of the protocol of choosing the modality. When continuing on CRRT, some are very comfortable. They start the patient on CRRT, forget about and leave it on the ICU nurses, and they take care of the every decision. So that is not the true CRRT. So there are many things. You can evolve on quality of the machines, quality of the fluids. You can reduce the cost of the fluids which we are using right now. So there are multiple things. Everything you can research on every aspect when you're talking about the research. But definitely we need to have, first of all, collect the data, what we have in our resource limited countries, how we can optimally utilize. Like at many places I have learned that there is a lot of hesitation in using peritoneal dialysis. But during my residency, we have done approximately more than 500,000 of the peritoneal dialysis. So there was never a hesitation. Anybody used to call and we used to put catheter 4, 5, 6 all together. We used to start in 3-4 hours, 6-7 patients on the peritoneal dialysis. So that used to be the time, because at that point of the time we have only 9 machine hemodialysis machines. Now we have 125 dialysis machines. So situations change. In every ICU cannot be equal. The requirement of the patients might be different. I think we must have one checklist in ICU. Our staff should be trained enough. Many times, as someone has told, if you don't have nephrologist, but sometimes a very good nurse can assess your patients. This is the vital of the patient. This is the urine output of the patient. This is the electrolytes. This is the acid base of your patient, and they can inform. You can take the decision from the distance that no, this patient needs to be started on this modality of this end, and your trained staff can do this. So, but definitely we should not live on this trained staff. There must be supervised training before you can say that no, this staff is liable to take the decision. This staff is liable to connect the patients on the dialysis if already vascular access is there. So multiple things. We must have one checklist: patient assessment, equipment readiness, whether the procedural steps, whether nurse is following, vascular access, how good it is there. Then monitoring. Dr. Vivek Gupta was telling infection. Infection in ICU is a very bad things which we all encounter. Right? Resistant organisms everywhere. So that kind of things we think even infection in ICU are a good subject to research. Why our ICU patients are so much resistant to so much of the newer antibiotics. We start antibiotics using today. In 1 month or 2 months of the time, the drugs are resistant. How we can stop this misuse of the antibiotics? Your patients improved, you want to de-escalate your antibiotics, no one is de-escalating these antibiotics. So there must be one protocol when to de-escalate this antibiotics, when you want to stop this antibiotic, what you want to choose the antibiotic for your patient. Because there are multiple things to go for the research. Not only one thing, I will say.
I will interrupt you, Dr. Prasad, over there. I know there are brilliant ideas. All of them are brilliant ideas. So just for the sake of time, I will request all of the panelists also to think of 2 priority ideas, research ideas, which should be done coming as a collaborative one, or maybe in your country, and you can put that into chat box. I will invite now Dr. Yash to take up the second part of the webinar, which will be covering up this session.
Thank you, Dr. Prashant. I will go straight away to Dr. Yashar from Kenya. Where do you place simulation in training for the intensivists, especially in resource limited areas? It could be online training, it could be online simulation, as well as tele services, tele ICU. Now we have integration of renal replacement devices also with the telemonitoring. We have some of the ICUs, especially in the western world and part of Southeast Asia also. So where do you place, especially how relevant it is to the resource limited settings? Dr. Yasha.
Yes, I think using the online training, simulation training in this kind of device, this can help a lot in scenarios that we have limited resource and we need to train fast and quickly, and sometimes make the monitorization of the treatment from a long distance. So like here in Brazil, we have a continental country, and we have a lot of countries inside in Brazil. The scenarios, they are very different between the regions. In the north regions of our country, we have hospitals that are very long distance from the main cities, and sometimes we don't have nephrologists or intensivists there in that place. We have sometimes a clinician or anesthetist doing things, and we need to train this professional. And the only way to achieve this kind of training and get results is by doing that kind of using that kind of tool like online trainings, protocols, and checklists, So I agree, and I think it's very important.
Thank you, Dr. Bruno. So tele services, especially tele ICU and simulation, both have a distinct role. In fact, we were running few or five of tele ICUs, and they were quite resistant to start renal replacement therapies. Few of them were in Africa and one in Bangladesh. After much persuasion, we could start renal replacement therapy in two of those ICUs, and they were happy. Initially, there were some hiccups. Then our senior dialysis technician went there for some time. So we have to do some hand holding also whenever we go to such resource limited settings. My next question will be to Dr. Fades. As already discussed many times, cost containment should not cut the corners. Cost containment is an open intent to limit the cost, but as discussed previously, also we should not be cutting on quality. What is your take more relevant in the resource limited settings? Dr. Fadil.
For the cost to reduce the cost without affecting the quality, it should be a governmental يعني we should collaborate with the governmental and non-governmental يعني companies and non-governmental organizations. So by using that charity, they will release the load from the government. And I think in Egypt we have the Nefro Egypt campaign, which is started in April in 2024 in April, I think. This campaign, it's launched nationwide and the Dialysis Healthcare Initiative with 50, serving 50,000 of the patients in the country. We reached with this non-governmental organizations, we reached that now 2.7 patients per machine. And I think this is a very good ratio without loading the governmental cost. And I think also this will be reflected on the quality of the treatment.
Very rightly put, Dr. Fadil. Thanks for your comments. So now we are talking about one world, one health. And COVID saw a lot of globalization, global networking, and democratization of resources. Might it be knowledge, might it be manpower, might it be technology. So for renal replacement therapy also we have to have global networking as we are doing today. And we have to democratize whatever resources we have so that everyone has an equitable share. I will put my next question to Dr. Vivek. Already discussed many a times, but I will put it again. One size does not fit all for any intervention in ICU. Again applies to renal replacement therapy. We should not give that message that CRRT is must for all critically ill patients. There is a certain subset of patients where CRRT is required, but we should not be giving it as a blanket treatment for all renal replacement therapy. This can help us to contain the cost and use CRRT wherever required. Another question to add on this will be availability of resources, especially those centers which are not doing CRRT or dialysis daily or routinely. For those centers, the availability of resources, manpower, and other technology, whatever is required. What is your take on both of these, Dr. Vivek?
Very good question and very relevant question in the context we are discussing. And I'll say the three component what was just recently discussed, that training, quality assurance without compromise means decreasing cost without compromising the quality, and the third question what you asked, that availability of resources in the limited situation and choosing a right therapy. Probably it all goes together. So if I start with my training session, I will first of all train my ICU fellows first to identify patient who really needs renal replacement therapy, because the problem starts from there. Whatever method I can choose my own ways or as per the available guidelines and the available evidences. I can give them the targets. These are the things when you should look for. and you should raise the alarm for renal replacement therapy. And then we have to teach and train them that which modality is good for a particular patient. Like, for example, any patient who is hemodynamically stable, any intensivist will prefer a SLED. We will not prefer ISD in the ICU, but SLED will be a very good modality, extended during increasing the time for 8 to 12 hours, 10 hours, 12 hours. That good enough to even to management of the fluid during these procedures. CRRT restricted to those patients who are hemodynamically unstable, where high vasopressors are some situation where you cannot shift your patient, or any patient who is having traumatic brain injury. So those are the very specific indications where we should go for the CRRT. And once even these patients are stabilized, there is no problem. We can switch over to the low cost modality. This is a system we need to develop for training. The second component of the training, as you are saying about the competency, probably that's very important, because that is a very important point to cut down the cost of the therapy. So that training will start after selecting the patient and choosing the right therapy. It's a cannulation, because that is something associated with a lot of complications and failure of the therapy, as well as reducing the time for the therapy. So a core competency should be there for all fellows who are working in ICU for cannulating a right cannulation with unobstructed flow, whether it's the access port or the return port of the dialysis cannula. And then comes the training for the staff, that how we can reduce the cost by increasing the duration of the therapy, that respecting the alarm, their training and core competencies on which alarm, how they are supposed to react, whether it's a too much negative pressure alarm which is affecting the access line, or too much filter pressure alarm, so changing the therapy. So these all, they needs to be trained and talked about it, and their competency should be evaluated. And then coming on the second component of your question, that the quality, whenever you are working on the quality, your duration of the therapy itself is going to go improve, and your outcome will be better. And this is what we are looking for in any situation in an ICU patient.
Thank you, Doctor. So we understand cost cutting is not cutting corners. We have to indigenize, we have to have open resourcing, we have to share knowledge and our skills so that we treat every patient equitable. In whole scheme of things, we often forget very well trained personal manpower in acute care, the emergency physician and the anesthesiologist. They might not be working in the ICUs, but they should be included in a team who treats such patients. My next question will be to Professor Narayan, sir. Especially in resource limited settings, identification of AKI is also a challenge. Many a times these patients are missed in the emergency. Many a time these patients are in the ward, creatinine rising slowly. The physician or the surgeon is not much bothered unless there is severe acidosis or severe hyperkalemia. So timely identification, timely arrival, and timely referral to the ICU or nephrologist as required, and recognition of AKI as a syndrome, and working towards etiology of AKI. These will be key challenges in resource limited settings. If you can please elaborate, sir, briefly on this.
Thank you, Dr. Yes, for this wonderful questions. It is always a challenging thing to recognize the patient who requires actually the renal replacement therapy. So when we have recently published one data on AKI, right? You must that was of approximately 3,500 patients collected from all across India, from all top institutions, AIMS, JGPJ, and PJ Chandigarh, from all corners of India. What we have observed, still the patients coming to the hospitals, 80% patients have a community acquired AKI. And they are coming late. Usually either they are referred late, or somehow they go on taking some of the local remedies, particularly in the settings. It might be the different settings in private sectors, but in public sector hospitals, they come after some treatment, some indigenous treatment, some other kind of the treatments, that is delayed referral to our hospitals, and by the time the patient has already a settled stage 3 AKI requiring renal replacement therapy, you do not have any information on your baseline serum creatinine values. Many patients have the comorbidity that you understand the diabetic patients, whether the patient had the diabetic kidney disease or not at the baseline. There is no information many times. No serum creatinine value was not there. Then you go on what would be this really the chronic kidney disease or this is acute or chronic kidney disease. What kind of situation is there? Definitely some component of AKI is there. So definitely these are the situation. Once the patients are admitted again, once admitted in that also depends on center to center, even the public centers where we are working, that is a well equipped center. So everyday monitoring of the urine output, monitoring of the serum creatinine value, electrolytes, and acid base balance. That we have eye over all these things, and most of the times when the patients are stable enough, then only the situation comes of the indication dialysis. Whenever indication, dialyze this patient if the vital is stable. When the patient is in ICU settings, requires ICU care, like if the patient has the respiratory problem, patient has the multi-organ dysfunction syndromes, then definitely the choosing the modality and these things are come. One thing I want to give the message that three important indications whenever we choose to go for CRRT only, that is the condition of the cerebral edema, either because of the patient having the trauma or any other reasons, or fulminant hepatic failure, patients going into encephalopathy. We thought that there is cerebral edema. And third important things, not that much absolute, but if there is too much of sometimes the bleeding risk is there, definitely you do not go for the CRT choosing, you go for the intermittent dialysis that can be went away. Or if you have the cited with dialysis system is there, then you can choose for it. But one thing is definitely there. Then CRT we go for. If the patient's vital is stable, definitely we go for the intermittent dialysis. Mostly not in ICU, as Vivek has already told. Most of the patients we shift to the ICU only when they have some vital instability. So multiple things are needs to be monitored. Urine output, you have no information when patients came to you, how long the patient is not passing urine. You do not have information of the previous serum creatinine value. You just guess the patient having the multiple comorbidity. It is possible that you may guess that patient has some underlying chronic kidney disease. On the top, the patient develops AKI. So, but classical indications remains classical indications. Like if the patient is in pulmonary edema, hyperkalemia, metabolic acidosis, any urinic organ damage, very much very high blood urea nitrogen the serum creatinine value. Definitely, you go for immediate some modality of renal replacement therapy. Sometimes you have the patients coming even AKI with the uremic pericarditis, very severe pericarditis. Not wet, you go for RRT. So this is the way we choose and manage our patients whenever the patient gets admitted.
Yeah. Thank you, Dr. Narayan Prasad. So we understand there is a need to recognize AKI as a syndrome and to timely try and refer such patients to the place wherever they require, could be nephrologist, could be ICU, or wherever the patient requires the site of care. I will hand over to Dr. Prashant. I'll thank all the panelists and request Dr. Prashant to summarize the session, please, sir.
Thanks, Dr. Javeri. I think we, in last almost half an hour, we heard a lot about the training and the competencies. And, despite working in different settings, we all agree that our workforce need to be trained. And the best outcome only achieved when you talk about a trained workforce, which has been regularly quality assured. And we are maintaining at least minimum competencies. We are assessing them up. There is a good discussion what happened on that, and then we talked about how to build up a collaboration, and I will end up with each one of us telling your at least one research priority. What do you think which can be done in future coming 2 years, and how to we can use this network to build up that research network, probably taking this forward people who are really interested as like you to build up this network. So I will take that comment. And then finally, Tapas will be talking more about the whole panel and the survey which we are taking. That will be also something he will be talking in next few minutes. So I will coming back to Dr. Bruno. One last thing which you want to put forward, final comments, something which is burning in your mind, hearing all that discussion, which can be taken as a something research priority probably.
There is some important points that we discuss here, and when you have data and when you have a structure to organize your data and to see the outcomes, you can base it on this, start to make some research to understand your process and to get improve and improve the quality and the safety in the care that we offer to our patients. So when you look into a clinical governance program, we have 7 main points, and one of that main point is training of the team, is management of the team, is data, is the risk assessment of the papers and the labs and the things that are inside the care of the patient. You need to understand and to try to put the patient experience inside to the whole process and organize that to make the most important intervention to be effectiveness. So to be effectiveness means reduce cost and deliver the best care with safety.
Perfect. I think so. You talk about joint registry. That's what we need to look in. Coming to Dr. Ibrahim, 30 seconds, one top priority which you think. I saw a couple of them already there. Something still burning in your mind.
One top priority is just to unify and develop the training and a clear protocol for all intensivists and nephrologists and the general practitioner. Thank you.
Okay, great collaboration. That's another beautiful point summarizing today. Dr. Gupta?
Yeah. So as per me, the priority is because in what happens in the resource limited situation, we always delay these RRT, whether we are choosing a SLED or CRRT. So probably a research on the timing of this and associated with the mortality, probably we can get a better insight for survival of these patients, a better survival if we choose early. And possibly this will give us a good guide.
I completely agree. I think the large trials which have been done are only done, majority of them are in high income group countries. So I think future trials should look up what is coming from, I won't say third world, we are now first world representing at different levels. So I think the major data is not only coming from where people are, the research is being funded, but also from where the most of the population stays and the challenges are different. So I think that need to be represented in the future trials. Dr. Prasad, any last comments and maybe something which is still in your mind we want to give up for people who are wanted to do research or wanted to join with you?
Yeah, definitely. We should start actually. Whenever we talk about the randomized control trial, that is a very costly study, and it is not an easy study. So that needs funding. If you want to have any randomized control trials that is well monitored, so but what is doable for all of us, what we think that even this very good survey studies of what are the different modalities used across, what is the success rate of in terms of the technique, in terms of patient survival, in terms of the cost effectiveness, what are the different modalities used in different parts of the India in different ICU settings. That data at least can be collected, and when you are doing from this multiple study, that will carry the value, and there will be the value of publications. You will be able to publish in this good journals then. So my suggestion would be that we can start from there where there is no that much of this heavy funding is required, or if we are all are capable, we can have the funding, we can write the big projects. Always intermediate grants or the big grants comes from the ICMRs or A or some of the good centers. So who are interested in doing that kind of the research, I can help you in making protocols, and we can design the study. We can submit those who are interested and can do future research. There is always a scope of research on every front. We can have the research.
Thank you, Dr. Prasad. I think these were the pulse which we wanted to hear, and more of encouragement for young intensivists who or nephrologists who wanted to research, not just collaborate into what is happening in the high income countries, but to generate data from our own setup. I think that will open up doors to many other things. Coming back to Tapas, I think he's going to talk a bit more about survey, and we are right on time. Thanks, Tapas. And thank you all panelists. You are wonderful, giving all your suggestions and most importantly, your insights about such an important topic. Thank you. Thanks for the day.
Thank you, Dr. Nasa, and all would say moderators and panelists for this incredible evening. And I would be now saying that we thought about this idea, nephrocritical care research initiative, and we have almost right now having 12 to 15 ideas that we have discussed in almost over 90 minutes or like almost 120 minutes. So thank you very much, all of you. Now, before we conclude, I wish to draw your attention to one of the most important initiative, as we have many times during this discussion told about that we need data, and the data should not be skewed to the Western world only. Rather, it should come from the the countries where the most the low resource settings are there. And the first initiative that Nephrocritical Care Society has started, the Globe RRT survey, and this survey not only about the questionnaire. This is a very ambitious project, data-driven attempt to map the current RRT landscapes in low and middle income countries. And also we want to identify the barriers across the infrastructure, the workforce, the modality access. We discussed about CRRT, ISD, PD, SLADE F. So we want to also inform the future training modules, policy frameworks, and also even research collaboration as we have discussed just now. So we need your voice, and we need your center's experience also, and we need this survey to reach to everyone, be nephrologist, be intensivist, be the dialysis team supervisors also, and some of the people who are working in the resource restrained settings. So now I urge everyone to participate in this survey, and this is the QR code. And with this, I almost reaching to the end of the session, but as I have mentioned also that we want to announce some big news to all of our Nephrocritical Care Society members, as well as all the panelists, as well as all the attendees, that we are again coming up with a very unique initiative. This is the webinar number 24, and this is about sepsis and kidney. And the date is May 1st, and we will be discussing in length and breadth about sepsis and kidney. There would be 2 plenary talks, and there would be 1 panel discussion again on the global perspectives on sepsis and AKI. Are we speaking the same language? And also, we have added 1 interesting case capsule where 1 young trainee would be discussing about a case, how we managed a real world case walkthrough both sepsis and AKI organ crosstalk. And the first plenary talk would be none other than Professor Dr. Claudio Ronco. He has candidly agreed to talk about the first talk, that is extracorporeal therapies in septic AKI. I would say sepsis and kidney, the myths, the evidence, and the future. So please stay tuned for Nephrocritical Care future initiatives. And also he has promised to me that the Nephrocritical Care Society members would get discounts and also some free registrations to the much awaited the upcoming Vishenja conference that is coming in 1 month from now or 2 months from now. It is in the month of June. So there are a lot of things happening, lot of collaborations happening, lot of the countries are coming forward to shake hands together to take nephrocritical care to the next level. So with this, if there are no more questions, I would definitely say right now that the future is bright. And with me, Dr. Mohan, if you want to share some of your thoughts before we can conclude officially.
Yeah. Thank you, Dr. Tapasar, for the opportunity. And we had wonderful panel discussion, thought-provoking, innovative ideas pitching in. So, as a part of Nephrocritical Care Society, we are just compiling all of them. Almost we have got 10 to 15 ideas, compiling them, and we see how we can go ahead, collaborate, and do the excellent job, we all need to be doing. So, the future is ahead, and all the challenges that fuel the innovation, and we would love to take the challenges ahead and do a wonderful job. Thank you once again, everyone, for participating in this webinar, the panel discussion, the panelists and moderators. Thank you once again.
Yeah. So at the end, 2 lines from my side. Let's not only talk about change, let's be the change. Thank you very much.